epileptiform has been removed. So now they are called lateralized periodic discharges. Bipleds or bilateral independent pleds are called now BiPDs. GPEDs or PEDs, that is periodic epileptiform discharges or generalized periodic epileptiform discharge, just called generalized periodic discharges. Pleds plus is called LPD plus. SERPEDs or stimulus-induced rhythmic periodic discharges are called stimulus-induced evolving lateralized discharges. Triphasic waves, they are called continuous 2 per second GPDs with the triphasic morphology. So let's not go into all the things, but the first first five categories is what I'm going to talk about. Now, LPDs, you have to just take out the epileptiform from this particular terminology, but nevertheless, it's been known for a very long time. From 1952, it was first described and then properly defined in 1964. And if you look at it, if you take all the EEG recordings, both in the outpatient as well as the inpatient, if you take, it forms about 0.1% of all EEG recordings. So it's not that common, but in the ICU, it is fairly common. So that way, so if you take the overall EEGs, then it is uncommon. But then if you take EEGs in the ICU, then that forms a fairly significant number. Now, the definitions, and it's very important to remember these definitions. Now, the pleds or the LPD, they are repetitive. So that's the first important point. They're rhythmic. So that means when you say rhythmic means they occur at the same frequency. Lateralized, that's why it's called pleds. Focal spike and wave or spike wave or sharp wave complexes, that's why this is epileptiform in that sense. At regular or nearly regular intervals throughout most or all of the EEG recording. So that means if you record for 30 minutes, it need not be there for all the 30 minutes, but it is there for almost the entire recording. So that's the important point. You can't just say pleds if you have only, say, for example, 5 seconds or 10 seconds, and then it's not there for the rest of the 25 minutes. No, that's not pleds. It should be there for much of the recording or most of the recording. And the very important point, between the discharges, the background activity is coming back. And there is no clear-cut evolution. That means if something is happening every 1 second or 1.5 seconds, that inter-discharge interval remains the same throughout. So that's a very important point. If it is starting at once in 1.5 seconds, and then it gradually shortens to, it becomes shorter and shorter and shorter, and it becomes 3 per second or 2 per second or 4 per second. Now, that is not pleds. So that's very important. So the inter-discharge interval remains almost static throughout. So that's very important. So there's no evolution from that frequency. And the location also. So it remains the same location throughout the recording. That is a very important point. Now, what is this pleds plus? Now, the pleds plus is nothing but after every discharge, there is a rhythmic polyspike rhythms. That means there is some fast or rhythmic discharges, RD. That's what is called pleds with RD or rhythmic after discharges. So that is what it is. That has got a very high connotation with seizure. Now, bilateral independently occurring asynchronous pleds, that is called bipleds. Again, you have bipleds plus, because each of these pleds can have rhythmic after discharges, and that's why it's called pleds plus. And then sometimes, very rarely, you can get what is called chronic pleds. Now, pleds are generally, by definition, by nature, they are acute. And therefore, they generally disappear within about 4 weeks or so. But sometimes they persist, and they can persist for long periods of time, from months to years. But if something is persisting for at least 3 months, then you call it chronic pleds. So that is the definition. So if pleds is remaining even after 3 months, you call it chronic pleds, because acute pleds generally disappear by this time. So the features of pleds are or lateralized periodic discharges are, they are lateralized or they are focal, they are periodic or near periodic. They usually electronegative bi, tri, or polyphasic sharp waves or spikes. They usually 50 to 300 microvolts in amplitude, and mean duration of this is about 200 milliseconds, which means it comes to the sharp wave definition. Present for most of the recording. That's a very important point. And generally, that particular side background is generally a bit slower than the opposite side. And the background reactivity also on that side is altered. So these are some of the manifestations of or features of lateralized discharges. This is a good example of a lateralized periodic discharge. You can see here that it is predominantly seen at centroparietal region. You can see that, and it's occurring every 1 second or 0.7 to 1 second, 0.8 to 1 second. And that interval is fairly fixed. It's almost the same interval, and it's seen only on the right side. It's not seen on the left side, and it is seen continuously. It's no evolution. It is the same almost the same frequency, almost, not exactly the same frequency. No cerebral rhythm is going to have the same, absolutely the same metronomic frequency throughout. So that is what it is. So this is a good example of a lateralized periodic discharge. This time it is on the right hemisphere. You can see that it is phase reversing across the parietal P4. And that means it is the focus is at P4 in this case. And it is going on continuously like that. A little bit of expression is seen on the opposite side also, but that's just an expression, nothing. It is not an independent activity going on. Now, this is what in 1991, this gentleman called Rear. Now, he classified this into, I told you about the Pledz Plus, Pledz Proper and Pledz Plus. Now, what this Pledz Plus means is that it is the Pledz is the discharges are intermixed with the higher frequency fast activity called rhythmic discharges. And when you see this Pledz Plus, there is a high propensity for clinical seizures. So not all Pledz. So if I have to treat a patient, if somebody asks me, would you like to treat this EEG? I would say, no, I wouldn't treat unless I see Pledz Plus. I probably won't treat, because if I see Pledz Plus, then at some point, sooner or later, the patient is going to have an epileptic seizure. So should I wait for the first seizure or should I treat immediately? I may treat immediately. So that is the point. So you have to recognize Pledz Plus. Pledz Proper, you probably don't have to treat, just an underlying marker of an underlying injury. Now, this is you see that it's happening. This is the frequency. And you can see here very well that, you see, this is a poly spike. You see, that's a spike. And then this is that is the after discharge. You see that spike, and you can see a second spike there, and then the wave. And then you see a spike and a second spike and a wave. Now, and the frequency is pretty, between the interspike interval is pretty short. And there are these a little bit of fast activity which is happening, which is overriding the sharp wave. And when you see that, it is likely to produce a seizure. That's what it is. Now, this is another example of that. This is actually predominantly a right temporal Pledz, right hemispheric Pledz. It's a right hemispheric Pledz. And you can see some fast activity on it, a little bit, not the best, but at times you can see it. And now that time you can see that when it happens like that, it evolves into a seizure. You see, this is Pledz. At the moment, this is only Pledz, because you see only lateralized periodic discharges, predominantly seen over the right hemisphere. And because there are some rhythmic after discharges happening at times, this patient is likely to go into a seizure. You see the next page, and it has resulted in a clinical seizure, electrographic seizure becoming clinical. See, that is a very nice evolution, only seen on the right side. And it is happening in the right hemisphere. predominantly over the occipital, parietal, temporal region. Very nice evolving rhythm. So PLEDS plus results in clinical seizures. PLEDS proper, that means without after discharges, they generally do not result in clinical seizures. So that is a very important point, take home point. And this is, see, this is another, that's the same patient. You see, it's evolving very nicely from this. This is the previous page. And you can see that the seizure is it started off with the high frequency activity, continuous activity. So the PLEDS has become now evolved. This is called evolution of PLEDS into a seizure. You see, the frequency has become faster, and the periodicity has disappeared. Now it has become almost continuous, and it is evolving. And now it has spread to the opposite hemisphere also. And so this is what is called PLEDS plus becoming a seizure, electrographic, then clinical. So that is what it is. Now, bipleds is a very interesting point and a very important problem, because these are bihemispheric. That means both hemispheres are involved. Now, what differentiates bipleds from generalized lateralized discharge, generalized periodic discharges is that these are not synchronous. The two hemispheres have independent PLEDs. They are asynchronous discharges, and the discharges between the two hemispheres can differ in morphology, rate of repetition, amplitude, site of maximal involvement. For example, on one side, the maximum may be in the parietal, the other side it may be in the temporal. So, and the morphology can vary, the interburst interval can vary. So that is why it's called bipleds. Bipleds. As an example of bipleds, you can see that the right hemisphere, there are pleds going on. The left hemisphere also has got some pleds, predominantly seen in the occipital region on the left side. The right side, it's maximally seen over the parietal region. You can see that it's phase reversing across P4. On the other hand, you can see these are more posterior on the left side. They are not synchronous. You can see that they are independent of each other. And so this is a classical example of bilateral independent periodic lateralized discharges. This is another very nice example of periodic lateralized discharges. You can see that on the right side, the activity is predominantly seen over the occipital. You can see that it's frequently seen. On the left side, it is seen on the temporal. And so they are going at two different rhythms are going on periodically on either hemisphere. And therefore, this is called a bilateral independent PLEDs. Now what is the significance of this bilateral PLEDs, multifocal PLEDs? Very important. You see this difference between the regular PLEDs and this bilateral PLEDs. The nature of injury is severe. They either have large strokes, they have anoxia, they have massive infections, which is involving bilateral hemispheres involvement. 72% were comatose, as opposed to only 24% who have only PLEDs. So that means if somebody has bipleds, they're likely to have much more severe injury, and they're likely to be more comatose. The mortality is much higher, double that of the regular PLEDs. And mortality is very high if you have PLEDs, bilateral independent PLEDs, or multifocal PLEDs. If you have 3 or more independent cerebral foci within one hemisphere, that's called multifocal PLEDs. And it means more severe injury and more chances of being comatose and much higher rates of mortality. So that's what the indication is. Now you see that this is a good example of bilateral PLEDs plus. You can see the after discharges after every on the left side. See on the right side, it's going on. It's the same patient actually. Now what is happening is on the left side, you can start seeing the after discharges between these between, you see that this is one discharge, one discharge, one discharge, but you can see the fast activity just overriding the discharges. And that is called rhythmic after discharges, rhythmic RDs. That means it's become plus. So this is bipleds plus, and they have a very high chance of getting a seizure. The next page shows a left hemispheric seizure. So you can see that the right hemisphere is still showing only pleds. The left hemisphere is showing pleds plus, and the pleds plus is now generating a very nice seizure. It is evolving. So the presence of rhythmic after discharges, which means the presence of pleds plus, means very high chances of the person having seizures or getting clinical electrographic seizure, clinical seizure. So this is a very nice example of that. You can see that the right hemisphere is still having the same pleds going on. So that's what it is. Now, sometimes, very rarely, you can get what is called chronic pleds. Chronic pleds means that by definition, pleds which are lasting for at least 3 months. Sometimes it can go on for years together. And in a series, it's very rare. It's not very common. You can have, sometimes chronic lesions like tuberous sclerosis, porencephalic cyst, chronic brain abscess. All these things can produce chronic pleds. I'll show you one example of this is a chronic pled. And now, why do you say it's chronic pled? Because one is that, okay, this patient had an injury long back, and the patient is completely normal actually. Patient is walking around, but has got a mild right hemiparesis because of an old insult. And you can see that this is a very nice, see, this is a lateralized periodic discharge happening every 2 seconds on the left side. So on the right side, the background is fairly okay, no problem. And that's what is called chronic pleds because of a chronic old injury to the left hemisphere, but the pleds is persisting. The pleds is persisting. And in sleep, you can see that, you can see very nice sleep activity. The spindle is seen very nicely seen on the non-affected right hemisphere. The affected left hemisphere is not expressing the sleep activity much, which means that that hemisphere is damaged. And so that means the brain is actually, it's got an old injury, nothing new, but the patient has got pleds on the left side. And the normal right hemisphere is showing normal physiological activity. So that's a very important point. So you can get chronic pleds sometimes. It's a very nice, you can see that the left-sided pleds are going on. The right side, you can see the spindles very nicely expressed. So this is a good example of chronic lateralized periodic discharges because of some very old insult, remote insult, but it can sometimes result in pleds happening all the time. So what is the etiology of the pleds? You can see that in the etiology of the pleds, stroke, ischemic stroke and infection form 50% of all etiologies. So that's what it is. So if you see pleds, be sure that, oh yeah, this could either be infection or it could be ischemia. So that's what it is. Rarely other things, tumor, metabolic, anoxia, CJD, other things. So that's very important. So if you see pleds acutely, infection, stroke, that's the message. So there are a lot of mechanisms. The most important mechanism is basically what happens is there's an acute injury. The cortex is isolated from the subcortex. And the periodicity is when the cortex gets discharged, then it takes some time to recover before it generates the next discharge. That is what it is. So the cortex first gets isolated from the subcortex, and the cortical activity, when it happens, it has to take some time for it to generate the next activity. So then it takes some more time to generate the next activity. So that's what it's called the cortical recovery time. And the cortex is isolated from the subcortex. And then various mechanisms are there, epileptic transmission, neuronal excitotoxicity, and so on and so forth. But whatever it is, basically there is an acute disconnection between the cortex and the subcortex. And there's a cortical hyperexcitability because of glutamate hypersensitivity, epileptic transmission, viral induced fusion of neuronal processes. That's why in herpes simplex you get very high incidence of pleds. So that's what it is. So these are some of the mechanisms that have been done. Now, typically when you see pleds, this is a transient phenomenon. usually seen within 24 hours after the onset of a brain injury. The brain insult today, less than 24 hours later, if you take an EEG, within the first 24 hours, you're going to see plaques, or you're likely to see plaques if it is there. And very important, you can see that 50% of the plaques disappear after a week or so. 90% of plaques disappear within 4 weeks. So that's important. That's the natural evolution of plaques. And very rarely, we saw some examples, very rarely it leads on to chronic plaques, but predominantly, overwhelming majority of them will disappear. Now, how it disappears gradually, you saw that the interval, which was about 1 per second or so, slowly the interburst interval will keep on increasing. And then slowly they'll be replaced by just slow waves or some sharp waves. And then finally, the EEG becomes continuous. There is hardly any plates. So that's how it kind of slowly disappears. And the clinical correlates. 75% of the patients have clinical seizures, predominantly focal motor, and generalized seizures are more common with bipleds. Focal neurological signs in relation to that hemisphere damage. And obtundation, as we saw rightly, that bipleds means they are more likely to be comatose. So that's what it is. So is pleds an interictal or an ictal phenomenon? At the moment, it is considered as an interictal phenomenon. That is very important. Very rarely you call it as an ictal rhythm. Predominantly, it is still considered as an interictal phenomenon. And the same pleds can be due to multiple different etiologies. Neuronal injury, that's the main thing. It could be ischemic, it could be infective, it could be toxic, it could be metabolic. So that's what it is. So the injury is there, but the mechanism of injury can vary. So that's another point. And no unique anatomical site or distribution of site is associated. Any part of the hemisphere, if it gets damaged, can produce the same plates. Whether it is occipital lobe, parietal lobe, temporal lobe, frontal lobe, any region, no particular anatomical site is associated. And it can either be cortical or subcortical or combined. So that's what it is. Now let us come to the generalized. We saw the lateralized discharges. Now we are coming to the generalized periodic discharges, or GPEDs, GPDs, or they're called the repetition of frontal or occipital dominant. Now, as opposed to bipleds, which are asynchronous between two hemispheres, here they are generalized and synchronous over two hemispheres. That's what is important. They're relatively symmetrical discharges, and they are relatively uniform in morphology and duration, with definable and quantifiable interval between consecutive waveforms, with recurrence of waveforms at regular intervals. That is the definition of GPEDs. Now, first it was described in SSP in the 1950s, the Rademacher complexes. But you can see that apart from SSP, you can see it's most commonly seen in anoxia, Creutzfeldt-Jakob disease, and very, very importantly, and we are seeing this quite often now, drug-induced. I've seen it in baclofen, lithium, fencyclide, all kinds of drugs. And obviously, we sometimes induce anesthesia. Barbiturate anesthesia is the commonest, where you want a burst suppression pattern. So the burst is the GPED, and the suppression is the activity between the two bursts. So that's what it is. So induced burst suppression is by barbiturate anesthesia. So that's what it is. So you can actually induce a GPED. That's what is important. Metabolic encephalopathies, non-convulsive status epilepticus, and during a resolution of status epilepticus, if you have a generalized status epilepticus, when it resolves, it usually leads on to a non-convulsive status epilepticus before it becomes normal. So that is what GPEDs is. Now, they're broadly classified into two types. One is called the short interval diffuse discharges, short interval diffuse discharges, periodic short interval diffuse discharges. That means PSIDD, short interval. What do you mean by short interval? Less than 4 seconds. Between two bursts, the interval should be less than 4 seconds. And these are more common, and they are the ones that are commonest. And they're seen usually in anoxic brain injury, toxic metabolic encephalopathies, CJD, non-convulsive status epilepticus. All these conditions have what is called periodic short interval diffuse discharges. If the interval is longer than 4 seconds, then you call it periodic long interval diffuse discharges. They are more specific. SSP is the classical. Toxic like baclofen, ketamine, they can, and sometimes in anoxic encephalopathy. So the long interval, specifically the first condition you have to mention is SSP. The next condition you have to mention is toxic, which is baclofen, ketamine, and anoxic usually is a short interval, but sometimes it can produce. So, but very importantly, this is, now I will show you some examples. You see this is, you see that these are bursts. You can see these are very, these are spike bursts. These are diffuse. You can see that every channel is involved. It's a sharp wave, or rather a spike, and then followed by a wave. Then there is a complete suppression. Then the next burst, complete suppression. And the interval between these two is only 2 seconds, which means these are called short interval diffuse discharges because they are diffuse, they are discharges, they spike and wave. And so that's what it is. So what do you get with this? I'll show you. When you see a pattern like this, this is usually seen only in the ICU. You see this gentleman now, you see that this correlate of this is usually myoclonic jerks like this. You see this is a post-anoxic myoclonus, which is diffuse.
I didn't catch that. Could you try again?
Unfortunately, what is happening here is that there is this gentleman has suffered a cardiac arrest. And the first 6 hours after cardiac arrest, he has survived the cardiac arrest, but he's gone into a severe, cerebral hypoxia. And there is a disconnection. There is a cortical laminar necrosis. There is a disconnection between the cortex and the subcortex. And usually you'll have these kind of myoclonic jerks. And the EEG during this time is these short interval diffuse discharges with burst suppression between the bursts. This is a classical example of this is a little more chronic condition. You can see these the interval between two discharges is quite widespread. It's not, they're synchronized discharges, widespread discharges, both hemispheres. They're short interval because they're less than 1 second, and that's continuous. So this is a short interval, periodic short interval diffuse discharge, classical of CJD. They're sharp waves. These are sharp waves and spike wave. And this is classical of CJD. This is the first diagnosis one has to make when one sees an EEG like this. The first diagnosis, okay, what's your spotter diagnosis? CJD. That's it. The previous one, spotter diagnosis, anoxic encephalopathy. This is CJD. This is also CJD, classical CJD, short interval diffuse discharges, which are spiky. Yeah, that's what it is. And in between, with the anoxia, you saw they were flat. Here it is not flat. You can see some theta background activity which is going on, indicating a fairly severe, but at the same time not as severe as the anoxic encephalopathy. That's another good example of a short interval periodic diffuse discharges. And that's another one. Now, what can happen is that you see that now this is a short interval periodic diffuse discharge, but please remember that I showed you in the lateralized periodic discharges, which we saw some rhythmic after discharges. Here you are beginning to see some rhythmic after discharges, even though they are quite widespread and diffuse. And you see that these discharges are seen. That means, and now slowly the interval between discharges is slowly coming down, and now it is becoming more and more continuous, and it becomes a seizure. You see the evolution between, I'll go back, the evolution between short interval periodic diffuse discharge, then it becomes rhythmic after discharge, then it becomes, the interval becomes shorter between discharges, it becomes more and more continuous. See, majority is continuous. Sometimes there is some breaking happening. And when it becomes more continuous, it means it's developing into a clinical seizure. You can see here that the patient is jerking, and that is what it is. So you can have periodic, short interval, diffuse discharges, which slowly becomes continuous and evolves into a seizure. So that is a very, very important point. You can see that that's a very seizure. Now, this is the seizure. When the seizure is ending, again, there is a breaking happening. You can see there's a break. The brain is breaking, and it is interrupting the continuous discharge by a break. Then again, there's a discharge, and then there is a break, discharge, break, breaking, and again, now there is a more and more breaking. It is again becoming periodic. So it started off as periodic, then became continuous, then became very continuous, then again starts breaking, and again becoming periodic. So that's very, so this is the dynamicity of the brain. So periodic to continuous, continuous to periodic. So that's what it is. That all depends on the excitability to inhibitory mechanisms which keep changing over time. Now, this is a very interesting one. You should never be satisfied by, or, you can see that this is one page, 10 seconds of the EEG, 12 seconds of the EEG. And you can see there is one burst. It is a diffuse burst. And that's basically a sharp, slow wave complex, which is seen diffusely. Now, the background is normal. The background is normal before the burst and after the burst. There's only one burst on this page. There's only one burst on the page. Then after some time, there's another burst. After some time, after some 15 or 18 seconds, there's another burst. Then again, nothing. Background is normal. So when you see like this could be isolated. These could be isolated bursts, random bursts. But you just see, I'm going to show you a video now. You see this video. Boy, yeah, now that he gets this. He gets that slow generalized myoclonus. Again, watch this. Yeah, that point. And during that myoclonus is what he gets these kind of slow wave burst, slow sharp wave burst. But the interval between these two is very long. It's very long. So then what I do is I compress the page. I'm compressing from 12 seconds per page. I made it to 66 seconds per page. That means 1 minute of the EEG is there in this one page. Then suddenly I'll find that there is a periodicity. So what appeared to be random and intermittently coming, these bursts, they actually have a periodicity. And this is called a periodic long interval diffuse discharge. Periodic long interval diffuse discharge. That is so any discharge that keeps happening randomly, or you think is happening randomly, now that can happen intermittent. Now that you have to do one thing is to see whether it's actually periodic and long interval. You have to compress the EEG and see whether there is a periodicity to it. Now, if it was occurring randomly, then the interval between these will be very, very variable. Here you can see that the interval is fairly fixed. It's about, let me count, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Every 15 seconds, we are generating a discharge. And that discharge is clinically accompanied by a slow myoclonus. And I can show that myoclonus. Yeah, that's the one. Now that is classical of SSP. Very early stage of SSP, the interval between discharges can be as long as 15 seconds. Now, and the background is fairly normal. So between the two discharges, in fact, this looks more like a idiopathic generalized epilepsy syndrome, because you can see that these are bursts of a generalized, sharp wave discharge, and in between the background is fairly normal. So you think, oh yeah, hey, this is quite random. It comes occasionally, and this could be an IG syndrome because the background is normal. But no, again, the history becomes important. And look at this pattern, that slow myoclonus. This is not a rapid myoclonus. This is a slow myoclonus, and that's classical. So always use the paper speed. You can compress the page and then see whether these discharges, which seem to be random, do they have a periodic pattern? And that's what a digital EEG can do. You can actually compress the page. So again, this is another very classical example of, this is how a SSP EEG will look more classically. You can see that they're not spike wave. Remember that SSP discharges are not spike wave. They're generally very large amplitude delta waves. And they usually, complex delta waves, di or triphasic delta waves. You get huge waveforms. The bursts which occur, and you see that every 3 seconds or 4 seconds or 5 seconds. Here it's a little shorter, obviously, but it can be, it's usually much longer. And then when you compress the page, you see that it is very, very periodic. And rarely you can get it at a shorter intervals, but classically, SSP is a slow spike and wave. Not spike and wave, sorry. It's a slow wave diffuse discharge, which is usually long interval. So you have now seen in the generalized discharges themselves, you have seen spike and wave discharges with short interval, classical of anoxic encephalopathy. Then you saw sharp wave and slow wave, short interval, classical of CJD. Then you saw that the slow wave bursts with the longer interval, which is of SSP. And you saw the kind of pattern, the myoclonus of post-anoxic damage, which is a rapid myoclonus. You saw the slow myoclonus of SSP. And then you saw how the continuum between periodic discharge and the continuous, which evolves into continuous activity, then again evolves into periodic. So periodic, continuous, periodic, that relationship between excitation and inhibition, the inhibitory mechanism, when it takes over, it becomes discontinuous. So that's what it is. So GPD mechanisms, GLUR, again, exactly the same like in the earlier one that I told, the recovery cycle between the cortex and the subcortex. That's very important. So repetition rate, again, depends on the cortical recovery time. How quickly the cortex recovers before it can generate the next wave. That's very important. So that's what it is. Now, what is the relevance of this? If you see generalized periodic discharges, what does it mean? So let us look at this particular study, very interesting study. 200 patients, critically ill patients undergoing continuous EEG. One group of ill patients were without generalized discharges. Another group of patients who had generalized periodic discharge. Both groups are sick. Now, what they found was the GPD, the incidence is about, in 3,000 consecutive patients, about 4.5% of patients would have GPDs. So that's a number that is there. And you can see that the commonest etiology was brain injury, systemic illness, cardiac arrest. Very rarely you see it in epilepsy. That's the point. So you can see that in chronic epilepsy, having an acute injury is not very common. On the other hand, acute brain injury, traumatic brain injury, anything due to systemic illness, cardiac arrest, these are the common etiologies. And there is, if you see GPD, then these patients have a very high risk of having non-convulsive seizures and non-convulsive status epilepticus. Now, the incidence of non-convulsive seizures is 27% in patients who have GPDs, as opposed to only 8% in those patients who didn't have GPD. Similarly, non-convulsive status epilepticus, the same numbers, you can see that. So that means the GPD indicates an acute cerebral injury. That injury can also produce seizures, higher incidence of seizures than in a person who does not have GPD. So that is what it is. But overall, the incidence of seizures is almost the same. And the poor outcome, obviously, if somebody's got a cardiac arrest, coma, non-convulsive seizures, that is the one that, So just because somebody has a GPD does not mean they can actually recover if it is due to, say, epilepsy or something like that. But the etiology determines the outcome, not the presence of GPD. That's the most important thing. Now, the etiology of GPD is because of cardiac arrest. Well, outcome is poor. If the GPD is due to sepsis, the outcome is not very good. So that's the more important point. Now, finally, I'm going to end another 2-3 minutes with this particular condition called stimulus-induced rhythmic periodic or ictal discharges. That is, there's a patient who's comatose, and when the nurses come and stimulate them in the sense that when they are doing their when we do our examination, or when the nurses are doing the suctioning or turning around the patient, anytime when the patient is being stimulated, you get a funny EEG pattern, and that's what is called stimulus-induced periodic discharges. And we still don't know what it means, but I don't have a good example of that, but this is how it will look. Suddenly, this year there's a stimulus artifact because they are trying to stimulate, doing something, some intervention is being done at this point, and all of a sudden there is a change in the EEG activity like this. Whether it is generated inside the brain or outside, we are still not very sure, but it looks as if there is a change. It looks as if it's an ictal discharge, but actually it is not. So that is what is called a SERPID. So in summary, the clinical significance of periodic discharges is uncertain. In other words, what we mean by uncertain is, should we treat aggressively right at the beginning or not? Some physicians will say, no, I am seeing this discharge, I have to treat it because the patient is very likely going to go into a seizure. But on the other hand, at least 2/3 of them will not go into a seizure. So that is another thing. So clinical significance, there's a lot of debate. Is it an interictal? Is it an ictal? How aggressively? Once you have decided to treat, what is the aggressive? How aggressively? Should you put them on a barbiturate coma and keep them quiet? Because you know that there is an acute neuronal injury, so you want to protect the brain. Or should you just give some simple anti-seizure medicine and then wait? So how aggressively to treat? Not sure. See, now clinical trial with anti-seizure medicine for possible non-convulsive status is indicated in most cases. But remember that even when you give medication, sometimes the patients may not respond clinically or EEG wise, but you want to do something. So, these are gray areas. We still don't know. And you can see that the same pattern is produced by a wide variety of etiologies. So the etiology cannot be determined by the pattern of the, except, in the generalized periodic discharges, the interburst interval will kind of tell you, okay, yeah, this is more likely to be SSP, this is more likely to be anorexia. But in general, majority of the times, the same pattern can be produced by a wide variety of etiologies. And I think what happens is that you have to be when you see a periodic discharge, you have to keep following up these patients with repeated EEGs, or at least, if you're not able to do a continuous EEG monitoring, at least you have to do EEG at frequent intervals, because I showed you some examples, especially when the patient has bipleds, or if the patient has got a pleds plus, that means you have rhythmic after discharges. Please ensure that you keep doing the EEG continuously, or at least very frequently, and because they can slip into non-convulsive seizures and non-convulsive status epilepticus at any time without you knowing at all, because the patient is unresponsive. So with that, I think I've taken about 50 minutes. And thank you very much. And I would be glad to answer any questions if there are. Thank you, sir. Thank you for patient listening. I stopped my screen share. Thank you.
Thank you. Thank you, sir. It was a very, very good lecture, sir. Very explanatory, and the EEGs you showed were very useful, sir. As usual, I think all would have understood very well. So they may not be asking questions. That was what I suppose. Anybody has got any doubt, any questions you can ask now?
I would be happy to, answer anything if, because there are no clear-cut answers. If you remember that, my own, this thing is that, remember, although we are not sure of the, the significance and all that, most important thing is recognize the patterns. That's the first thing. So these are all mental imageries we have to create in our mind. We have to store these imageries in the mind. Pledges, okay, you have to be able to remember the pledges. Okay, interburst interval is like this. Pi pledges, is it synchronous? Is it continuous? That kind of, so that's the more, then we talk about significance and all that. But the most important thing is pattern recognition.
Yes, sir. Very nice presentation, sir. And thank you very much, sir, again. And again, I tell all, we will be having the lecture on Thursday as sir has got some 2 p.m.
Yeah, sorry, sir, because no, 1 minute. Sorry. No, this is the latest development. If it is, see, I've cancelled that Nellore because they are predicting very heavy rain in Andhra.
Oh, yes, sir. Yes, sir. Another cyclone is coming.
Shall
we have on Friday itself, sir?
Then we can keep it on Friday itself, sir. This is about 2 hours back. I sent a message to my colleagues there and I said, see, I don't want to get stuck on the roads.
Okay, sir. We like the cyclone very much.
So we can keep it on.
We will have it on Friday, sir.
We'll keep it on Friday as
planned,
proposed and planned.
Sir, you can take more time also, sir. You can take 2 hours, sir. If it is a video EEG.
Fine, I will, sir, and I'll try to keep it. If it was a regular offline, in-person meet,
physical, yes, sir.
Then it would have become, very interactive because you stop, then ask,
yes, sir.
and then we discuss. Here it's nice, no problem, but you can't make it that interactive.
Sir, we are not leaving you, sir. We like to have a physical meeting next month beginning, sir.
We'll do that.
Between the Shine and the TANCON, we like to have one meeting, sir.
We'll do that.
I will contact you later, sir.
Okay. We'll do that, sir. Sure.
Sure. Thank you very much, sir. Thank you, everybody.
Thank you so much, sir.
Thank you, sir.
Very, very much. Thank you.
Bye, sir. Very nice, sir.
Thank you. Thank you.